Hi friends. So in this particular video, we are going to be discussing neurocutaneous syndromes. They are very important from a resident point of view because you frequently get these as long cases because they are going to have a wide spectrum of findings. So it's actually a combination of a lot of long cases when you get a neurocutaneous syndrome as a patient. So we need to be aware of the findings and the tumors that you want to look out for, the lesions that you want to look out for in these patients. So I will be talking about the criteria for the neurocutaneous syndromes. I shall be talking briefly about the theory and the genetics that you need to know behind these. And then the main focus is going to be on what are the spectrum of findings that we will look at. Each of these we shall be discussing individually in great detail in individual systems as to how you approach them as far as lesions are concerned, like brain tumors, liver tumors, adrenal tumors, and so on. But here it's like a brief review of what are the different findings that you should be aware of in different neurocutaneous syndromes. Also, they make for great spotters. So you have to be very careful. So something like this, this is one of the most commonly placed spotters in a lot of exams, because at the first instinct you think that there are multifocal nodules in the chest of the patient, and you mark it as multiple lung metastasis, or you call them cannonball metastasis, right? So this is what you have to be aware of, that it's not only the lungs, right? We always adopt a systematic approach, and I've talked about the outside in approach that I use. And you see, the moment you begin with the outside in approach, you see that in the soft tissue, in the chest wall, you are seeing these multifocal lesions. So these actually are not pulmonary lesions, they are actually on the skin, on the dermis layer. So these are neurofibromas. So the diagnosis of this lesion is going to be NF1. The moment you see so many dermal neurofibromas, it's NF1, right? So you have to be careful that at the first look, this looks like pulmonary lesions, but they are actually superimposition of the chest wall lesion. And the moment you look, that they are there below the diaphragm, they're there in the skin. So this is a pretty clear cut case. And once you have seen actually a patient of neurofibroma, no, the lesions are so distinct and conspicuous that you will never go wrong there. So that's something that we want to be aware of. Let's talk about the NIH criteria for NF1. So there are these 7 major criteria, and for a diagnosis of NF1, 2 out of 7 need to be positive. So first is the skin lesions, which are called as caffeole skin macules. As the name says, these are macular lesions, which means they are flat lesions which are hyperpigmented, coffee color, hyperpigmented. So 6 or more of these, the size is more than 5 in prepubertal, more than 15 in older individuals. 2 or more neurofibromas of any type. So this you see innumerable, right? So 2 or more neurofibromas, or even one plexiform neurofibroma, or neurofibroma involving an entire nerve plexus. So we'll see both of these. So this is for the name itself, neurofibroma. Axillary or inguinal freckling, this has also been called as the Grove sign. 2 or more Lish nodules. These Lish nodules are hematomatous lesions in the iris, right? So these are nodules in the iris. An optic glioma. Do remember, you may also have non-optic pathway gliomas here as well, but optic glioma is a major criteria. Bony lesions, which include either sphenoid dysplasia, thinning of a long bone cortex with or without pseudoarthrosis, and family history. So let's look at the various lesions. So what you see here are the classical caffeole macules. If I can give you some bit of information here about these macules. So they have this very smooth margin which has been likened to the coast of California. Right. On the other hand, you also have caffeole macules in another syndrome that we will learn, which is called McCune-Albright. So this is a syndrome where you have polyostotic fibrous dysplasias and you have precocious puberty. Here as well, you have caffeole macules, but they have irregular margins, which is likened to the coast of Maine. So M for M. And this is supposed to be these lesions with irregular margins, right? So this is about caffeole macules. This freckling that you see, this is the axillary freckling or the Crove's sign. And these are your Lish nodules, right? So these are the dermatological manifestations of NF1. Coming to the radiological findings, so these are the distinct dermal neurofibromas, which is the most common manifestation that you're going to see in NF1, and invariably by first decade, almost every patient is going to have these. So these are your dermal neurofibromas. What is very important for you to remember is these do not become malignant, right? So these do not become malignant. What becomes malignant are these plexiform neurofibromas. So these are your dermal neurofibromas. This is a VRT of an image which shows these cutaneous lesions very well. And this can also come to you as a very easy spotter, very, very classical. And now look at this. You have this entire nerve plexus thickened, the entire nerve of the brachial plexus being thickened. You see the classical target appearance of neurofibroma, wherein you see the peripheral hyperintensity and the central hypointensity. So this is the typical target sign that we've studied in neurofibromas. So this is a plexiform neurofibroma. Remember, around 10 to 15% of these neurofibromas become malignant peripheral nerve sheath tumor. And this is a tumor with a very, very bad prognosis, right? So these are going to be very aggressive. So when you see very heterogeneous, growing out of the margins, they are PET positive, show uptake on PET. These are your malignant peripheral nerve sheath tumors, all right? Talking about the bony findings, what you are seeing here is the cortical thickening, right? So there's the cortical thickening and you see a pseudo arthrosis formation, right? So there is a fracture with a pseudo joint formation. So this is what we call typically as the tibial pseudo arthrosis, very, very classical in NF1. And what you see here are these eccentric geographic lytic lesions, multifocal eccentric geographic lytic lesion with a sclerotic rim, no periosteal reaction, very, very well defined, sharp zone of transition. So these are these benign lesions which are NOFs. So non-ossifying fibroma, we have discussed this in bone tumor class. So when you see multiple NOFs, always consider two DDs. One is going to be NF1. So you can remember from the name itself, NOF is NF1. And the other differential here is going to be a syndrome, which is a variant of NF1 called as Jaffe-Campanacci syndrome. So this is Jaffe-Campanacci syndrome. So these are the NOFs that you see here. Talking about the ribs, we again see cortical thinning. So these are described as pencil thin ribs, right? So these are known as cortically thin, pencil thin ribs. In addition, you see that there is scoliosis, but do keep in mind that scoliosis is not a major criteria. Even though this is the most common finding, it's not a part of the major criteria because frequently the scoliosis is secondary to the neurogenic tumors, right? So it's because of the neurogenic tumors that we are having the scoliosis. So it's not a part of the bony major findings. When we talk about the CNS findings, this is a schematic diagram from Osborne's where we see that this is the plexiform neurofibroma. You can see the different fascicles here, which is growing along the temporal aspect of the orbit. So this is a very, very classical image where you're going to see that there is sphenoid dysplasia, because of which there is going to be herniation of the meninges and there's going to be proptosis. And then you see this neurofibroma. So this spotter comes and look at this CT, classical CT, where I see that the arachnoid, the fluid here is herniating anteriorly, and you have the soft tissue mass which is growing along the temporal aspect of the face. So this is a plexiform neurofibroma. What you are seeing here in this VRT, so beautifully compare it from the right side, you see that the greater wing of sphenoid is absent. So what you see here is the sphenoid dysplasia, a part of the major criteria. Sphenoid dysplasia, you see greater wing of sphenoid is absent. That results in the widening of the superior orbital fissure. And on the X-ray, what you see, the orbit looks empty. So this is what has been likened to the bare orbit sign. Again, a very classical spotter for the exams. On the CT, the corresponding thing, because of the sphenoid being absent, right? So it either can be dysplastic or it can be completely absent like this case. We see that there is anterior herniation of the meninges, and sometimes there can be an arachnoid cyst here as well in the middle cranial fossa, which results in proptosis. So this is what you see, and sometimes there may be associated plexiform neurofibroma. So these are the findings that you see near the orbit. Another manifestation is the